Thalassemias are a group of inherited disorders that cause a decreased rate of synthesis of a structurally normal globin chain, which is a quantitative defect. These disorders are characterized by microcytic and hypochromic red blood cells and target cells. Thalassemias are classified according to the globin chain affected and are found in Mediterranean, Asian, and African populations. The severity of thalassemias can vary widely, from no clinical abnormalities to transfusion-dependent conditions, and in some cases, they can be fatal. Thalassemia major is marked by severe anemia, where either no alpha or no beta chains are produced. On the other hand, thalassemia minor, or trait, involves mild anemia but sufficient production of alpha and beta chains to make normal hemoglobins A, A2, and F, although they may be in abnormal amounts. Beta thalassemia can be categorized into major or homozygous, also known as Cooley anemia, and minor or heterozygous. In the major form, there is a markedly decreased rate of synthesis or absence of both beta chains, resulting in an excess of alpha chains. This means no hemoglobin. A can be produced and the body compensates with up to 90% hemoglobin F. The excess alpha chains precipitate on the red blood cell membrane, forming Heinz bodies and causing rigidity. These cells are either destroyed in the bone marrow or removed by the spleen. Symptoms typically appear by 6 months of age and include hepatosplenomegaly, stunted growth, jaundice, and prominent facial bones, especially in the cheek and jaw areas. Iron overload from red blood cell destruction and multiple transfusions can cause organ failure. Laboratory findings for beta thalassemia major include severe microcytic and hypochromic anemia, target cells, teardrops, many nucleated red blood cells, basophilic stippling, Howell-Jolly bodies, Pappenheimer bodies, and Heinz bodies. Increased serum iron and bilirubin levels reflect the hemolysis. In the minor form of beta thalassemia, there is a decreased rate of synthesis of one of the beta chains, while the other beta chain is normal. Laboratory findings show mild microcytic and hypochromic anemia with a normal or slightly elevated red blood cell count, target cells, and basophilic stippling. Hemoglobin A is slightly decreased, but hemoglobin A2 is slightly increased to compensate. Alpha thalassemia is categorized into major or hydrops fetalis, hemoglobin H disease, minor or trait, and silent carrier. In the major form, all 4 alpha genes are deleted, resulting in no normal hemoglobins being produced. This condition leads to the production of 80% hemoglobin BARTs, which cannot carry oxygen and is incompatible with life, causing death in utero or shortly after birth. Hemoglobin H disease occurs when 3 alpha genes are deleted, leading to a decrease in alpha chains and an excess of beta chains. Hemoglobin H, an unstable hemoglobin, is produced, and Heinz bodies form, causing rigid red blood cells to be destroyed in the spleen. This condition is characterized by moderate microcytic and hypochromic anemia, with up to 30% hemoglobin H and the rest being hemoglobin A. In the minor form, 2 alpha genes are deleted and patients are usually asymptomatic, often discovered accidentally. Up to 6% hemoglobin BARTs in newborns may aid in diagnosis, but it is absent by 3 months of age. The silent carrier state involves the deletion of 1 alpha gene, resulting in mild microcytic and hypochromic anemia, often with a high red blood cell count and target cells. A borderline low mean corpuscular volume may be the only sign, and patients are asymptomatic, often not diagnosed unless gene analysis is performed. Thalassemia and hemoglobinopathy interactions are caused by the inheritance of a thalassemia gene from one parent and a hemoglobin variant gene from the other parent. The severity and symptoms really depend on the specific interactions. Common interactions include hemoglobin S/beta thalassemia, hemoglobin C/beta thalassemia, and hemoglobin E/beta thalassemia. Hematology tests are essential for diagnosing and monitoring various blood disorders. Blood cell enumeration using manual methods involves several steps. For a manual white blood cell count using a hemocytometer, you start by diluting a well-mixed EDTA, whole blood sample 1 to 20 with 3% glacial acetic acid. Allow 10 minutes for complete red blood cell lysis. Then fill both sides of the hemocytometer and allow 1 to 2 minutes for settling. Next, using bright field or phase microscopy, Count the white blood cells seen in the 4 1 mm corner squares on both sides of the hemocytometer, using the 10 times objective. The total area counted is 8 millimeters. The formula to calculate the white blood cells per cubic millimeter is total white blood cells counted times the dilution factor, which is 20, divided by the total area counted in millimeters times the depth, which is 0.1. An alternate dilution factor and area counted can be used, but appropriate adjustments must be made to the formula. Other diluents, like 1% ammonium oxalate, can also be used. For correction in the presence of nucleated red blood cells, the corrected white blood cells per cubic millimeter formula is 100 times the uncorrected white blood cells divided by 100 plus the number of nucleated red blood cells per 100 white blood cells. For a platelet count, dilute a well-mixed EDTA whole blood sample 1 to 100 with 1% ammonium oxalate. Allow 10 minutes for complete red blood cell lysis, then fill both sides of the hemocytometer and allow 10 minutes for complete settling in a humidified chamber to prevent evaporation. Using phase, which is preferred, or bright field microscopy, count the platelets seen in the center 1 mm square on both sides of the hemocytometer, using the 40 times objective. The total area counted is 2 millimeters. The formula to calculate the platelet count per cubic millimeter is total platelets counted times the dilution factor, which is 100, divided by the total area counted in millimeters times the depth, which is 0.1. Sources of error involving manual cell counts include a specimen being clotted, the sample inadequately mixed before diluting, equipment not thoroughly cleaned or dried, and technical errors due to evaporation on the hemocytometer, diluting or plating following procedure, counting of cells, and calculating results.